Our next speaker is a hard-working radiologist, Hildegunn Aase. She's actually reading about 10,000 screening examinations, which means 40,000 mammograms every year. So, and in addition to reading all those mammograms, she's doing a PhD. And she's the head of the screening breast center at Haukeland University Hospital, which is one of the largest breast centers in Norway. And Hildegunn will give a presentation from one of the studies she has performed in her PhD.
Thank you very much for your kind introduction. I'm going to talk about digital breast tomosynthesis or digital mammography. Does it make a difference? Breast Screen Norway invites women aged 50 to 69 years to a two-view digital mammography every second year, hunting for breast cancers, like we see here, in the lateral upper part of the left breast. Screened women are shown to have 20 to 30% lower breast cancer mortality compared to non-screened women. The five-year relative survival for women with breast cancer is 92%. Still, breast cancer is one of the cancer types responsible for most cancer deaths in women, 12%. The sensitivity of digital mammography is close to 90% for women with fatty breasts. But for women with more dense breasts, the sensitivity is 50 to 60%. Further, there is a 4 to 5 times higher risk of breast cancer in women with dense versus fatty breasts. Can you see the cancer? It is perhaps a little more easy to see this cancer in a 1 millimeter plane of a digital breast tomosynthesis. In digital breast tomosynthesis, DBT or 3D mammography, the X-ray tube moves in an arc above the breast while taking several low-dose images of the breast. The breast is compressed between the compression pedal and the detector. And these low-dose images are later on reconstructed into several low-dose, thin planes through the breasts. Different vendors have different equipment. Hologic have an X-ray tube that moves in 15 degrees. GE, the equipment we have been used, have an X-ray tube that moves in 25 degrees, and Siemens moves in 50 degrees. Studies have shown that digital breast tomosynthesis increased detection rate with 1.6 more breast cancer for every 1,000 women screened. The recall rate has been shown to vary. In European studies and in Europe, the screening is performed in a similar way as in Norway. A meta-analysis have found a light increase in recall rate. But in the US, where the recall rate usually have been 3 to 4 times higher compared to in Europe, the recall rate was lower after the introduction of digital breast tomosynthesis. The question is, the increased detection rate, with this increased detection rate, will we also see a decline in the interval cancer rate? Or, what about overdiagnosis? Is the increased detection rate in digital breast tomosynthesis only an increase in overdiagnosis? And an overdiagnosed cancer is a cancer that would never have presented symptomatically in the absence of screening. And we are not interested in increasing the level of overdiagnosis, we would like to get the killing cancers to have a lower rate of interval cancers and to reduce breast cancer mortality. This is a synthesized 2D image of a DBT, which is reconstructed from these low-dose images taken, which is reconstructed to this 2D synthesized 2D image. And then this is without using more radiation. And this is how the radiologists look at the digital breast tomosynthesis. We see all the thin planes, and here we can also see a cancer in the lateral part of this right breast. DBT or digital breast tomosynthesis, what's the better method? And how can we evaluate this? Of course, we can look at breast cancer mortality, but then we have to be very patient. We can wait 5, 10, perhaps 20 years. We can also look at detection rate, but then we also have to consider the interval cancer rate. Also, the rate of false positive screening test, the rate of women recalled, where we have no cancer detected, is also interesting. And economy, the time the radiologist used to read the images. In digital mammography, we have only 4 images, while in digital breast tomosynthesis, we have approximately 250 images. So time we have to consider. And storage and IT issues. In digital mammography, we have a digital mammography takes 32 megabytes, versus a digital breast tomosynthesis can be 2,500 megabytes. And speed of the IT systems we have to consider, and also, of course, the rate of overdiagnosis, which is difficult to measure. To have some more information about digital breast tomosynthesis and digital mammography, we have performed a randomized controlled trial in Bergen. All women aged 50 to 69 years invited to screening in Bergen between January 2016 and December 2017, that was 44,000 women. And 75% of them attended screening. They were all asked to participate in this to-be trial. The women with implants and the women not accepted the invitation had digital mammography and were not included in the trial. 89% accepted the invitation, they signed the consent, and were electronically randomized to have 2-view digital breast tomosynthesis with synthesized mammograms or digital mammography. 50% in each arm, more than 14,000 women in each arm. The main result was published in the Lancet Oncology in 2019, and we found no statistical difference between DBT and digital mammography regarding screen-detected breast cancers. We found 95 breast cancers after digital breast tomosynthesis and 87 after digital mammography. The recall rate was lower in our trial in digital breast tomosynthesis compared to digital mammography. And the positive predicted value was higher after digital breast tomosynthesis compared to digital mammography. And now I'm going to present some results of a study on mammographic features, where the aim was to compare the distribution of mammographic features in women recalled after screening with digital breast tomosynthesis versus digital mammography, and to assess associations between features and the final outcome of the screening examination. We did recall fewer after digital breast tomosynthesis compared to digital mammography. No difference between level of breast cancers, here in blue, but we found a higher rate of women recalled with a false positive screening test after digital mammography compared to digital breast tomosynthesis. If we have a look at the mammographic features of only the breast cancers, we see that there are a higher rate of women recalled with a breast cancer in the feature speculated mass in the DBT group compared to the digital mammography group, which is in light blue, DBT in dark blue. The other features had no significant differences, but we can see that in the feature calcification was the most frequent feature with breast cancer after digital mammography. If we look at the mammographic features of women with a false positive screening test, we have these results, and in this case we have several significant different results. And of course, in this setting, the lower bars are the better ones. We can see that it was most women recalled with a false positive screening test in the feature asymmetry, and more than twice as many after digital mammography, which is in the light orange, compared to DBT, which is in the dark orange. And if we have a closer look at each feature, we can see that in the feature speculated mass, we see that almost all the recalled women had a cancer, the blue ones. And more cancers were detected in DBT compared to digital mammography. In the feature indistinct mass, we had no differences between level of breast cancers, but we found more women recalled with a false positive screening test after digital mammography compared to DBT. The same result in the feature asymmetry. We had more women recalled with a false positive screening test after digital mammography compared to DBT. And also in the feature obscured mass, there were more women recalled with a false positive screening test in the digital mammography group compared to DBT. And so far, all the features had also no overlapping 95% confidence intervals. In the classification group also, we had more women with a false positive screening test after digital mammography. However, in the feature architectural distortion, it was the opposite way. We found a higher rate of false positive screening tests in women with after digital tomosynthesis compared to digital mammography. And also in the feature circumscribed mass, we had more women recalled with a false positive screening test after digital breast tomosynthesis compared to digital mammography, and only a few cancers detected. In conclusion, we identified differences in the distribution of mammographic features after digital breast tomosynthesis versus digital mammography. And speculated mass was most common mammographic feature among recall diagnosed with a breast cancer after digital breast tomosynthesis, while calcifications was the most common mammographic features for recall diagnosed with breast cancer after digital mammography. And the percentage of asymmetries, indistinct mass, and obscured mass in women recalled but not diagnosed with a breast cancer was lower for DBT versus digital mammography. And further studies exploring the clinical relevance of the different mammographic features are warranted, and more knowledge might enable radiologists to improve the benefit-harm ratio in screening. Thank you.
Thank you, Hildegunn. This was a very nice presentation of a great study. There was several questions, but I have to pick one, and that is a little statistical. It could be a nice pilot for the dissertation ahead. Very soon, Pia Ganluka, he asked, have you also checked effect sizes? Even if some results had a negative p-value below 0.05, could you see clearly different effects? One could see, he says. So there may be an important clinical significance even if there isn't a statistical significance. Can you comment on that?
Sorry, I didn't.
In spite of a non-significant p-value, could there be Could there be some connections, things that could have significance even without a significant p-value? That, I guess, is
clinical perspective.
Yeah, of course, we don't want women recalled without having a breast cancer. So, and also it depends on the size of the study we have performed. So, yeah, and also with more information. It's not sure that later studies will give the same results as we had in this study. This was the first time the radiologist performed DBT. Therefore, we have now learned more. And if we perform screening with digital breast tomosynthesis, perhaps the results will be different and perhaps even better. We have learned, and I guess that the knowledge we have got after these studies, perhaps will be able to perform the screening even better, and yeah.
There was also this short comment whether you would welcome an AI tool, considering your high number of reading mammograms every year.
Yeah, Solveig are working together with the breast center in Bergen, of course, and she has great plans for introducing artificial intelligence at the data on the TOBI trials. So we are looking forward to working together with Solveig and the cancer registry on that, of course.
But as a clinician yourself, you would, Solveig, please comment.
I think that I want to add, as a result of the TOBI study, that did not find statistically significant differences, we found clinical significant differences, but it has also resulted in a kind of waiting in Europe for implementing digital breast tomosynthesis in the screening setting, because there are several studies, but there had not been any randomized control trial before the TOBI study, and that's why it's very a good design of the study, and it has a lot of power. So you could be proud of that we have really stopped the radiologist and the screening programs in Europe to implement tomosynthesis without thinking and having the knowledge that is needed before we change. I think we should be proud of that.
That's for sure.
And also, you can mention that in the TOBI2 trial, we have also got some new knowledge about what we have detected in the TOBI1. And we did not get any statistical significance on the interval cancer rate in TOBI2 compared to TOBI1, but still we had some fewer interval cancers in the DBT arm.
More, I think there are more information to come, more results to come also, Thanks a lot for, I think this has been a great session, very nice with the diversity of the speakers concerning their background. Thanks a lot to all of you, and as a token, fantastic contributions.
Thank you.
Thanks. I think let's give an applause. Then we'll close this session and have some coffee and meet again on scheduled time at 11.